Your red blood cell membrane, skeleton, and plasma membrane is comprised of ankyrin, protein, and spectrin. And hereditary spherocytosis is an autosomal dominant mutation that affects these proteins. And so you're going to have small, round, red blood cells with no central pallor, decreased surface area, and also a premature removal by the spleen, which leads to extravascular hemolysis. So the findings are splenomegaly, because the spleen's doing a lot of work, pigmented gallstones, aplastic crisis, parvovirus B19. And the labs are going to show a decreased mean fluorescence of red blood cells in the eosine, the EMA binding test, increased fragility in the osmotic test, and normal to decreased MCV with abundance of red blood cells. And so splenectomy is the solution. So here, let's talk about this. We got some complications: pigmented gallstones, aplastic crisis, especially with parvovirus B19. And let's look at this practice question. A 15-year-old girl presents with pallor and jaundice, anemia, elevated LDH, indirect hyperbilirubinemia. Peripheral smear shows spherocytes, and Combs test is negative, not like the agglutination there. So what is the greatest risk of developing? Pigmented gallstones. That's one of the complications. So we have chronic hemolysis. That leads to increased unconjugated bilirubin, which then precipitates in the gallbladder as calcium bilirubinate stones. Trap answers. Autoimmune hemolytic anemia. That would be a positive Combs test. Sickle cell causes hemolysis as well, but think pain crisis and avascular necrosis, not as osmotic fragility. Hemochromatosis, that's just iron stuff, man. That's chronic transfusion states like beta thalassemia. Splenic infarction is common in sickle cell, but not hereditary spherocytosis. Okay, hopefully that was helpful. Yeah, I know this one isn't fun to learn, but just membrane defects in the red blood cells, deformities, extravascular hemolysis, splenomegaly, jaundice, and pallor. We'll see you in the next video.